my question was kind of what you were just talking about. In a book I read recently called Panelists by Paul Ovid, he talks about how we use one drug to get off of the opioids, and so, and of course this has been going on for a long time. You know, back in the 1800s, 1900s, they were giving opioids to babies when they were teething, to pregnant moms. So my question is kind of what you were just touching on, but it's kind of for all three of you, is what do you see in the future, like mistakes that we could make? Like, could we potentially go down this road again of prescribing heroin to get off of opioids? I mean, is that, from an economic standpoint, a medical standpoint, is that something that in the future you see us have a problem with?
Well, I think so. Your question is, what do you think may be a trend or something starting now that may be detrimental in the future? I've already seen it in my field treating cancer patients, is not getting opioids to the patients who need them. So certain pharmacy companies in the country will just say, you can't get a certain number of pills from us and that's it. Doesn't matter the reason. And they'll quote a guideline and say, well, the such and such guideline says we can't do it. And then they don't look, and we were talking about this earlier, 4 fonts smaller than the rest of it, and there's an asterisk that says does not apply to cancer patients. But they have that difficulty. So my feeling is, unfortunately, I think the pendulum is going to swing on back, and there are proper indications and uses for it, and those people are going to be put in the middle.
I guess I'll add on to that too. With a lot of these policies as well too, they're certainly well-intentioned, but a lot of policies have unintended consequences. And so you can think back to when they did the reformulation for OxyContin to make it crush-proof. One of the downsides of that is that people started using hydrocodone more, and people started switching to heroin more. And so you had this, again, what's going to be the next substitute? And so, yeah, I don't have a solution for that. I guess I wish I did. If I did, we'd hopefully be out of this problem. But we'd have to think very carefully about what type of policies we want to do, and again, what are going to be the unintended consequences of those policies.
Yeah, I was gonna give you 2 really quickly. One is as we decreased our prescription of opioids, we've increased overdose due to fentanyl and heroin. That's one. That's something we've seen that's happened. The second is something I'm really passionate about, is that there are certain disadvantaged groups, and I think we would all agree that we have, most physicians would agree that we had an over-prescription epidemic, but there were certain groups that were not prescribed to the same level as others. Some of those were women who had abdominal pain. Some of them were people who looked like me, who went to emergency rooms, who didn't get opioids to the level of certain majority groups. And so I have a concern that those groups, as the pendulum swings, if we continue those discrepancies, that those groups may have untreated pain after surgery, in the emergency department, etc. And so I think that's something we also have to watch.
So just real quickly, I know we've got lots of people with their hands that have been up for a while. Is there any precedence for moving something out of that Schedule 1 classification? Has that ever happened before?
Good question.
Well, Dan, well, they heard your questions. So, okay. Now, I mean, one thing, something brought up, and with people checking, but heroin is legal in some countries in Europe as a medicine. And there's been, if you look at the conspiracy theory blogs, what they'll tell you is that an American pharmacy company had the patent on morphine and a British company had it on heroin, so the United States made it illegal to protect the morphine trade. So that's a conspiracy blog. I can't quote that. I didn't have to say. But some of those things, but where you meet someone who's trained in another country and come over here. So in my field, I also deal with hospice patients. And in England and Ireland, there's something called a Brompton's cocktail, which is heroin to kill the pain and cocaine that they can stay alert and enjoy time with their family. And that is a standard, and anybody knows, could not prescribe this here in my wildest dreams. But yet patients will tell me I'm in pain, or when you give me the pain medicine, and I sleep through the time I have with my family. So sometimes the Schedule 1 has to be proved, but with some of the things on there, it isn't an absolute. Somewhere else that it's used, it's actually found to be a useful tool.
Gentleman at the bar. Yes, sir.
Do you think that we will ever be at a point where DNA results can be used as a way to assist doctors prescribing opioids to maybe see trends that help slow down that abuse?
So I guess the question is that testing for DNA or scientific testing, could that help you? So we've started to learn a few things. So most of the medications that you take are processed in the liver. They're detoxified or they're given a twist if they work or something. Someone had discovered people would go in and have a mixture of one of the lower scale opioids would be a combination of Tylenol and codeine. And they would go and they would get this medication. They would come on back. It's like, it's not really helping that much. And they say, well, here's some more. It's not really helping that much. So someone asked later, stuff like, well, you're seeking. This should be working. And then they found in this group of population, this ethnic population, depending on how you look at it, but between 68 and 84% of that population lack the enzyme to activate the codeine, and you're giving them nothing better than Tylenol. But that's how they got labeled. I think as our molecular, whether it's DNA or liver things, I think you will be able to in the future see that and see somebody and look at somebody's liver or do a baseline like you do in a physical, and then there'll be things labeled on there. We already know is a different medication, an enzyme called G6D, which processes things. But if you lack that, certain medications get toxic. So if you all ever watch MASH, they even showed that in an episode 30 years ago. They knew that. But Klinger was of Lebanese origin. That ethnic group doesn't tend to have that enzyme. And then when they made him take his malaria medicine, he got sick, and they thought he was gold breaking. So we know that it's there, but I think the technology, we're just waiting for someone to apply it or put a purpose behind it, and then we can look at that.
It's not there yet.
No, but hopefully there.
The place that has it the most is cancer and psychiatry. Psych meds and cancer meds are a little bit further along. Pain meds just aren't there yet. About your question about Schedule 1 moving out. So I don't know that it's imminent that Schedule 1 will move out, but the FDA is considering letting testing occur on some molecules like LSD and psilocybin and some things that have been forbidden to be even tested. So there's a move at the National Institutes of Health to try to go back and look at some of the drugs that have been forbidden and say, is there a role that we haven't looked at? So you may see some of that in the future.
Yes. No hands. They were like, yes, ma'am, in the blue. Yes, ma'am, in the blue. You got it.
Okay, either one of the doctors. My question is concerning when you treat a patient. I know with acute pain surgery, you're going to have to give pain. If you have someone who has chronic pain, what is your goal in trying to prescribe? Are you trying to get them to zero pain, or are you trying to get them to a tolerable level, or how do you determine? Because I don't want to sound cynical, but we all live with pain. I get up, I have a little arthritis pain, but I go about it my day. So when you have to talk about somebody who has chronic pain, where do you set the bar of what is tolerable?
So the question is, when you have someone with chronic pain, what's your goal when you prescribe? What are you trying to get them to? I would say that what the conversation in my practice has changed, evolved over the past 5 years. But right now, when I see a new patient, I ask them, what are they unable to do that negatively impacts their quality of life that they wish that they can do? And that's my goal. And so if someone says, I want to go to Walmart and be able to walk around for an hour and shop without having to sit down or without having to ride a motorized scooter, then that's now our goal. If I have someone who is very active and their goal is to run 10 miles, and they used to be able to run 10 miles, but now they can only run 5, then that's my goal.
I think, and as the sort of the mirror image of that, I ask them if they've been taking anything, and has that helped them, or has that helped them with functionality? And if it has not improved their functionality, it's not improved the things that they want to do, then we just stop it and we try something else. So, I mean, the definition of madness is trying the same thing over and over again and expecting a different result. So if they say, and we've changed the medicine, we've increased the medicine, we've given it some time, and it's not working, then we sort of discuss that this is just not appropriate, it's not helping your functionality. If with chronic pain and something has improved and it does give someone that functionality, then that's the part that we sort of monitor and try and keep in the best dosage range or cut down minimum, and I will still, and I will come out to somebody if I've seen them long enough for something to say, hey, there is something else out here now, would you like to give it a try, or someone is trying things. Always keep reassessing and always keep reevaluating.
Fortunately, I've not had pain problems, but if I did, say I had surgery or something like that, do you have any recommendations about finding a physician who has lots of different modalities and might be able to help me?
So the question was, is that how do you find a physician that has modalities available to them, or that does well? So there are certifying boards out there, but I think if I were not in the field of medicine, or let me say, if I were looking for a dentist who did a thing and they said they were certified by the dental board, I really don't know if that's a real board or something that Five Guys created. And there are definitely people out there who will certify themselves as the such and such pain group, or certified by the Southwest Arkansas Board of Pain, and it's 7 guys that meet in a bar like this. What I have found that patients have said, and what success is, just like anything in else life, if you can go to a blog, if you can go to a website, if you can go to something like there, and people will tell who helped them. Or people will say where they can go, or you can ask them and people can have some go back. And then afterwards you can ask about their credentials and see. But word of mouth is usually both word of mouth in how well patients have done, and then word of mouth, if you've treated a couple of other physicians' patients, they came back and said you're great, you're going to get more and more referrals from them, and sort of say.
Yeah. I was not asking you to answer the question. I was saying that he's a good doctor. But I think also physicians know, and so ask a physician who they would send a family member to. I think that's the most telling thing. I work with a lot of doctors in my hospital. There's probably 6 or 7 spine surgeons. There's 5 or 6 hip surgeons, but everyone knows who they would call if their mom needed a hip replacement. And so I think that question really cuts very quickly to the heart of who you should see.
Question in the back corner.
Hi, I have a question in reference to the chronic pain more than the surgery. So, for instance, a lot of chronic pain is associated with inflammatory conditions. So, like endometriosis, rheumatoid arthritis, and such. So, is there any biological markers to measure pain instead of just setting a goal, like can you walk through Walmart, that you can actually measure to quantify improvement?
So there was a question of if there are biological markers for chronic pain. So there, actually just this past week, there was a company that claims that they have found a biological marker and that they're going to release it kind of it was on Twitter, on Twitter. No, but it wasn't just a company on Twitter. It was actually it was tweeted by a doctor that I respect, who was a part of that process in finding the marker. I think that pain is a little more, this is opinion, again, so this is not evidence-based. I think that pain is a lot more complicated than blood pressure or cancer or a lot of the other diseases that we treat, because I think that there is both a brain and a mind component to pain. You can't separate, there is the physiologic, you stub your toe and the nerves send the signal to your brain part of pain. But there's also the fact that we all experience pain differently. All of us could have the same exact pain. Some of us wouldn't move. Some of us would jump out of our chair. Some of us would cry. Some of us would say really bad 4-letter words like me. But I think that's an important part and we can't ignore it. And I don't think a biological marker gets to that.
Yes.
A lot of Far Eastern religious figures deal with pain through mind control. Do you know anything about that and how it works?
So the question is there, based on what's practiced in the Far East, are there mind control or medication or other things to help with pain? So there are some things now that we're looking for the idea. There's been a new wave like mindfulness now has come out, and that's one thing that some people have helped focus chronic pain. attitude. There's been a study that has sort of shown that once you've told somebody, like, you probably will not be pain-free, but with patients have an acceptance or working around it, then afterwards their pain score drops. And some of it is sort of how they interpret the pain. And I give the biggest interpretation about there is a component, how do we tap into that or teach people that, is this example of that. And having been in the Navy, you hear about somebody, and if they had a wound, and it was from a car accident, and it was interrupting their normal day, and they're going to miss work, and kids, and why did this happen to me or whatever. There's a lot of distress, and there should be. No one's doubting that wound. But then you talk to people who have been doing a tour of duty, and they're patrolling somewhere, and they get a wound, and they get it, and they hurt, but they look down at that wound, it's like, I'm going home. And that's a total different. That was documented very well on the beaches of Normandy about a lot of people got it. They didn't seem to be in the pain medication because they got to go off there. It's the perception of it. So I think the potential is there, but I don't know a way to sort of mass distribute it or get it out at this time. It would be worked on, but I think it is possible.
Do you know anything about why pain seems worse at night? When you're trying to sleep, or just at night, pain seems worse, whatever it is. Is it because you're not distracted?
The question is why pain seems worse at night. And I would say that I have patients who say that their pain is worse at night. I have patients who say their pain is worse in the morning. I have patients who say their pain is worse with activities. So I think everyone experiences it differently. I think some of it's that we're tired, and I think sleep is restorative. And so it helps our body to heal from kind of the little bumps and bruises and the wear and tear on our body throughout the day. So I think that's part of it. I think that when we're trying to sleep, we're not as easily distracted. And so it allows us to focus in on our pain a little bit more, especially when we're trying to get into a comfortable position. So I think there's a few things that contribute.
Yes.
I heard a segment on NPR the other morning about your body produces opioids. So first of all, I wanted to know how that works. Secondly, the premise of the segment was people who had arthritis or chronic pain, if they would exercise, like walk, I think they were recommending walk 3 to 5 days a week, and that the more you did this, the more opioids your body produced, and therefore you would have less pain over time. So I was wondering if you could kind of speak to that a little bit. Is that a true thing? I mean, how do we produce opioids?
So I'll jump in that. So the question was, our body produces opioids. How does that work? Can that be increased through activity? Our body produces opioids. It produces cannabinoids. It produces a lot of medicine that we take are just kind of an artificial version of things that we already have and that we know help us with whatever that condition is. I will kind of come at it from a different angle from the other side, and hopefully that will kind of answer your question in a roundabout way. And so one of the biggest things we're looking at in the anesthesia literature is opioid-induced hyperalgesia. And so it's the idea that when you have too much opioids, your body actually becomes desensitized to pain. Because when you have pain, you don't produce those endogenous opioids or those opioids that are naturally produced in your body. And also the receptors don't work as well because they're constantly used to being fired. And so I think if the opposite has to be true. And so if we depend on our endogenous, our natural opioids and promoting them through exercise, through movement, for arthritis, when arthritis is normally worse in the morning, a lot of times because you're stiff, and moving helps. I often use the example of being on a plane. If you've ever flown across the water or taken an 8 to 12 hour flight, it hurts to get up. And you don't want to get up, but then not getting up makes it hurt more, and you get in this vicious cycle. But the thing that breaks the cycle is actually moving and stretching those joints. It gets lubrication, it gets blood flow. And so movement is essential. And I'd also add something that I think is important is diet too. We have to watch food is medicine. It's the most important medicine. We take it all day, every day. And so when we take in inflammation, I think it grows inflammation in our body. For example, smoking. I don't know if there's any more inflammatory thing that we can do to our body than to inhale fire. And so I think that if we smoke, smoking cigarettes, I try to encourage all my patients to stop smoking if possible.
Hypnosis is great for that.
That is true.
I guess to step outside of my own expertise here to add my own opinion for this too. We've also talked a lot about the psychological process as well too, and getting out and walking for 15 minutes is going to help with the psychological aspect of that too, and so that's going to contribute to feeling better as well too. So,
Linda.
So I have a question about, I've been told that I have a high pain threshold. So one of the times when I had some broken ribs and it was extremely painful, I had a hard time communicating that to a physician because they didn't understand that I gave birth 4 times with no pain. So when I say it hurts, it really hurts. So I don't know how to, how you have those little smiley faces on the chart that says, is this the worst pain I've ever had? Or, usually I say, it's not that bad. But I said that I could birth too, right? So I don't know how to explain that to a physician in a way that they won't, that I'm using the right words that we can communicate. And I just wondered if there was some way that you could advise us on how to communicate individual personalized pain.
So what are your trigger words? Like when you're hearing a patient, are there certain things or certain terminology that you hear that makes you think, wow, that's big pain, or not so much?
Well, for one of the things that I go around and categorize with patients is just, so we have a pain survey that the physicians in my group answer every day on an inpatient. And one of the things we ask them about in Pain Differently is like, are you having any other symptoms at the same time they're doing it? Like, is your mood down? Are you having problems sleeping? Does it cut your appetite down, to give you an idea of how it's doing with global function? And another thing is how is it doing with your function? And sometimes people will say the pain, well, it rates this, but it's like, well, how is it affecting you right now? It's like, well, if I'm sitting still, I'm fine, but you cannot pay me $1 million to walk up and go to the bathroom and get the remote. So that's like, okay, so that's a different sort of thing. So there's something that helps diagnostically, but it helps give a global idea about how pain's doing function. And then if they tell me, it's like, well, I can sit here and deal with it, but it's like, I don't want to get up, I don't want to walk down the hallway, those sorts of things. And we say, well, we've not addressed it well enough, because it should be your level of function should be appropriately up. And if you said those broken ribs, but what are you doing? What would you have done yesterday before the broken ribs that you would not do now, even if I held up $100? Okay.
This is, hopefully this will kind of help your question some. It's more to the question I got from the side, is where I sit in my office, when patients come in, I actually have a perfect view of them walking down the hallway to go to the scale. And that's purposeful, because that's actually probably the most important part of my examination, is watching patients walk into my clinic. Because it gives me an idea of their function, it gives me an idea of their pain. I get to, and their gait often can give me ideas to their hip pain, their back pain. A lot of times I can tell where a person's hurting just by watching them. And so I use the same when I see patients in the hospital, is just being observant and being present and allowing a patient to talk about, listening, just something that we don't do a great job of as physicians. And really, I think that if we slow down and actually listen, I think we would hear you. And I think we also, as patients, and I've been on the other side multiple times, especially with my children, it's hard to advocate and navigate the medical field. And I'm a physician, and most of the people who treat me or my children, I know personally. And I have trouble sometimes advocating for what I need or what my children need. And so I feel for people who are trying to navigate our medical system without the knowledge that I have, because it's really challenging. You have to meet people for the first time. You have to trust them with your with your health, your life, your most important information, your money. And so we have to do a better job of listening and response.
Yes. Nope.
I walked to a pharmacy and I approached the pharmacist who has prescriptions from my doctor. But I also see on the side, I've got everything from A to Z that has nothing but anecdotal evidence of its effectiveness. None of that medical science is proven, it's just the vast majority of the stuff that people are inundated with, that this will help you. Okay, so now you're talking about holistic medicine that's been around for 3,000 years. You're talking about techniques that have been around for a long time. There are ways to measure that, are there not? You take blood samples before and after. There's something measurable. There's still science involved. I know there's politics, and I know there's an AMA, and I know there's all these things that don't let you do what you need to do. So if you can choose one thing that you think that needs more medical research, what would you suggest that might be?
I don't prescribe anything.
Yeah.
So it was a discussion of all the alternative or complementary or therapies that are out there, and if there was one thing that I think needs more research, what would it be? For me, 100% diet. That's what I think it is for me. I think that we need to, and I know that's a crazy answer, and I see a lot of people shaking their head and looking at me like I'm crazy, but I think that there are ways that we can change our diet to treat many of the diseases that we deal with on a day-to-day basis. And I think that there are, I'm again going to be a Debbie Downer, I think that there are forces that push us to, the way that nutrition is traditionally taught is wrong, and I think it's driven by industry and commercial interests. And I think we need to do a better job of understanding how what we eat contributes to the diseases we have, including chronic pain. Now, if I took a step, the next one, I think personally would be acupuncture. Because I'm a real believer, I think it works. I have personally seen it work on me and my family members. And so anecdotal evidence is very powerful. And so I think we need to study it much more, and that's something that I hope to do in my current role at UAMS at some point, when someone gives me the finances and resources. If one of you wants to invest in an endowed chair or stool for me to research acupuncture or diet, I would absolutely love it.
I think, I was just going to add to yours real quick. What I would like to see, so you only get a certain choice in certain you get a 15 milligram pill, you get a 30 milligram pill, you get a 45 milligram pill. It lasts 6 hours, but in this person it lasts 8 hours. So this patch, but it's supposed to come off. I would like to see a device like our patients with diabetes have, that they can fine tune what they give with insulin, and then they only need 17 milligrams of this medicine a day, but the smallest tab it comes in is 25 milligrams. And I think that's sort of individualized. And I also believe in acupuncture, and I have a GI Bill, and I've been strongly thinking about putting that towards it. But as far as something I think where the technology is there and they can advance it, that would be my idea.
I guess I'll be the cynical one now for this time around. I guess I don't know how much we're supposed to do this either, but just the thought process of the diabetes thing, when you can sort of control it, that seems like that was like the motivation behind the slow release OxyContin. And so I think there's going to be a lot of, you have to be very careful with how this would be administered as well too. So that would be my Debbie Downer cynical kind of look towards something like that. But yeah, the bottom line is it comes down to information. And again, doctors learn by either A, research, or B, experience. And so being able to have those tools is going to be funded by research, fueled by research. So you need to be able to have those endowed chairs over there that you can do this type of research. But otherwise I don't disagree with anything that these two had to say about that.
Yeah, and I just want to add anecdotally, so I've worn lots of different hats in my life, and I had a background in the arts, and probably 5 or 6 years ago, I got a grant that was funded by the Cancer Institute Auxiliary to provide dance and movement therapy to breast cancer survivors. So I was very much interested in that complementary medicine space, recognizing we don't have a lot of data on that. How can we move in that direction? And I'm not an expert, and I don't mean to represent, but just generally what I found on my journey, the amount of funding that's available pales so much in comparison to the amount of funding that's available for any number of, well-established medical conditions. So the NIH, there is a branch of the NIH that now funds complementary medicine research. It's not been around as long as many of the other institutes. The National Endowment for the Arts will fund medically related research. But just the volume of what's available, and for example, looking into getting like a music therapist in place in a hospital, if you look around the country, some of the most established programs are still funded through philanthropic dollars. So just the funding mechanisms that are available to study this arena are so less developed than what's available for everything else, and I think that factors into it as well.
There's been a lot of discussion this evening about differences in the ways that patients experience pain. And I liked what you said about basing your therapy on how it interferes with their life. How do you catch the cheaters? You understand the question?
So the question is for people who are the cheaters or the people who are taking therapies and that don't need them. So one thing in my clinic, if you agree to come to my clinic, you agree to a random urine drug screen anytime I want one. And if you decline it, that's your right, and I'll also be telling you about where you're going to find your next doctor. So it's a reason. And we to be convenient, we will do it on a certain number of patients at random, but when they come to the clinic. But they also sign on there that if I say, oh, I'm coming up to a clinic, maybe I'll take a couple of pills, and the urine test positive, and I'll sell the other 58, which is a big problem. So we also say it's like, hey, we know it's 10 days before your appointment, but you have a day to come in and get it, and then at the same time, we're going to check your urine, but I'd like you to bring your pill bottle, and we're going to see how many you should have left. I'm going to do that.
But there's still the people then who take the pills because they're addicted, but they don't have pain.
Well, but we look at that, and we do screen for addiction. We ask about functionality, and there are signs that people say, as horrible as chronic pain is, it's rare that someone can't say that they didn't have one good day or one moderate day. But when even that's a little bit of a generalization. But if there's sort of an ever-increasing request for more, and ever-increasing a refusal to try other things. So I sort of feel like a pain patient. You want to try, you want to explore out, but if they say, I'm willing to do anything, doc, I want to get rid of this pain. And then you say, well, Gilligan's Island, or you want to try these others. Well, I won't try that. And then let's get back to the topic of pills. That's sort of a sign about that, or that they weren't seeking, but they may have become addicted to it. Patients also, sort of with the addiction, they get a fear that it gets taken away, and sometimes they won't endorse that as well. So they may come in and we have to worry about, like, they need 15 milligrams and they're on 30 milligrams, but they're afraid to say, well, I think I can do better. And then I just say, well, I'll take all the milligrams. And you don't need it. And from that. So another is just having a dialogue with the patient again and their expectations. But it can, we try to put these mechanisms in place, but I also sort of tell patients, it's sort of like, I can do all of these things. I will do everything I can in my power as a physician to help you, but if you're not going to try and help me, I'm going to be powerless. And then hopefully that gets a dialogue of what they're doing.
Yes, ma'am, in the striped shirt.
How do you get a pain doctor? In Little Rock, Arkansas, if you are a cancer patient or in severe pain, it's been my experience that it takes 8, 10, 12 weeks to even be seen by a pain specialist.
Wow.
So the question is, how do you get a pain doctor in Little Rock? So to cut down, it's usually a referral from another physician that is sort of appropriate, and then it's the physician. But I can say very proudly in my clinic, if the physician sends or the patient says, like, I've been waiting for a while and I'm in a bad place, my nurse will come and find one of us and say the lady needs to get in. So the longest I've had to make anybody wait for someone who said they really needed to get in to see me was the length of a 3-day weekend. The length of a 3-day weekend when my clinic is open.
My husband was had rectal cancer and he could not get a pain doctor, and the oncologist did not feel comfortable increasing his morphine, and he was in horrible pain and never had effective pain management.
Wow.
Gentleman in the back booth there.
A lot of the conversation tonight has kind of been around the finances of will this get reimbursed, what types of treatments do we have available, whether that's opioids, whether that's stents, whether that's tons of different things we've talked about, Suboxone, new chemical therapies that become available. Maybe kind of a big picture question, how do you think a single health payer system would hinder or help that process? Would it make it more efficient to be able to have people treated appropriately, or would it put more barriers in place?
All right, so this question was about the single payer system and whether that will help or hinder. Well, the first thing it would help would be for the people that, or for the majority of the U.S., they get their health insurance through their employer. And so for the people that aren't employed, this is a hindrance, a significant hindrance. And so a single payer method would essentially bypass that. And also from the labor market perspective, it also slows down people from wanting to switch a job. If I like my health insurance where I'm at, I don't want to switch that job and move to somewhere else where I may be more productive or more efficient in that regard. And so there's going to be plenty of benefits that are going to be difficult to measure from that regard. I guess I'll pass it over for the other side for when it comes to the doctor's side of what they deal with, I guess, on their end. But
I think it's hard from the physician side and from the treatment side. I think it's hard to say, and that's not a good answer. But I guess I'm being Debbie Downer, but so I'm just gonna be honest. I think, and I'm leaving my politics completely out of this conversation. Every plan has specific things that they cover and specific things that they don't. And so if we have a single payer plan, then we'll have to make decisions about what's covered and what's not covered. And we talked about a lot of things that I think a lot of us would like to be covered. And if the decision was made that that's not covered, then that's not covered, and that will not be available, in the U.S. And so I think there's benefits to that because it could expand coverage to things that, if we make the decision to cover hypnosis, for example, then that may change our entire medical practice. But if we make the decision to not cover opioids, for example, then that's going to change our medical practice too. And so I think there's pluses and minuses to having kind of one system make those decisions for our medical system.
Can I comment on that?
Yes, please, Teresa.
So in the U.S., we already have an example of this. It's the Veterans Administration. And so the VA does make buprenorphine, Suboxone available for treatment of opioid use disorder. Interesting, it also makes yoga, particularly yoga and particularly acupuncture available. The problem is not the payer. The problem is the availability of prescribers who will take this on. You don't have to be an addiction psychiatrist, nor do you have to be a specialist in treatment of opioid use disorder in order to prescribe Suboxone to treat opioid use disorder. You do have to be a licensed prescriber who's completed, right now it's 8 hours of continuing education, although that may change. And so the point is that it's not just a payer problem. It is also a willingness to treat problem. The VA has also, and one of the reasons I think it's important to look at the VA as an example is there's something called the Mission Act that requires VA to allow veterans to go outside the VA for care. Well, in the case of opioid use disorder, in Arkansas, it's been a big deal because the VA has very few prescribers available to treat opioid use disorder in Arkansas. However, the availability of other physicians outside the VA to treat opioid use disorder is also severely low in Arkansas. And so it's not just a payer question. It's the willingness to come together and treat these problems. Because we talked a lot tonight. I was waiting for somebody to say Suboxone. Can you tell? Because we talked a lot tonight about the need to treat pain and the need to use opioids carefully to do so. But the fact remains that there's a lot of people out there who have opioid use disorder who really cannot stop using their opioids until either these guys have to prescribe opioids for them or they're going to get them illegally or somebody needs to treat opioid use disorder. And it's not just a payer problem, it's availability of treatment problem. It's an access to providers who will treat it. So it's not just about paying, but we can see it. One thing that is possible, as Dr. Goree said, is if you have a single payer system, you can make some big decisions about what you're going to make available. And VA has made the decision that while we're going to make these different things available, the problem then comes is, just like some of you have asked questions around how do I find a high quality provider to manage pain? Well, how many of you know the difference between a high quality yoga instructor and one that's not? Right, some of you do, but many don't.
And just to take that one step further too, imagine going from an urban setting to a rural setting, what happens to the availability of those types of resources as well too that would also need to be.
Absolutely. And in Arkansas, there's almost half of Arkansas counties, over half are considered rural. And among those, something like 37% have 0 Suboxone prescribers, and another 10 or 15% have only one. So that's not very many Suboxone prescribers to distribute, even though there's only 3 million of us.
Thank you, Teresa. I hate to cut everybody off, but we are out of time. So please thank our panelists up here one more time. James Fletcher, Johnathan Goree, and Teresa Hudson, who just added to our conversation back there. If you want to stick around and talk to these individuals, I'm sure they'll be happy to talk with you. Thank you for coming. Please remember your wait staff if you haven't already taken care of them. And we're here next month talking about CRISPR gene editing. Thanks for coming out.